Hi, my name is Dr. Shiraz Patel. I'm a board-certified orthopedic surgeon with a specialty in fellowship training in hip reconstruction and in total knee reconstruction. Thanks for choosing me for doing your surgery. I just want to go in detail what we're going to be doing with your hip replacement. All the hips that I currently do now are through what's called an anterior approach. Instead of making the hip incision on the side or posteriorly, the incision is all going to be made in the front. The advantage of going through the front are several. Number one, it's less invasive. Number two, we're not detaching what I feel are important restraints for long-term stability and long-term survival of the hip. I've done hips through 5 different approaches, and this approach has clearly been the best, and now probably the last 3,000 we've done through this approach. Let me kind of take you through what we're going to be doing. So you'll be asleep for surgery. When you're asleep, we map out what your leg lengths look like with a computer navigation system, so I know what I'm starting with and what my goal is to end with. The incision is made through the front. We part the muscles like curtains and get down to your hip. Now this is a model of a left hip, and if we look at the left side of the hip, normally normally the ball of a hip should be round and smooth like a cue ball when you play pool. This is an example of an arthritic hip, bone on bone. There's no cartilage left. The socket should be smooth and white like the porcelain in a toilet bowl, and you can see how chewed up this is. So this is why you have so much pain in the groin and go radiating down to your knee. When we do the surgery, we're going to go in there, remove the femoral head. I expose the socket, clean the socket out, bind in a titanium shell, put in 1 or 2 screws with a plastic liner. I roll the leg out, bind in a titanium stem with a ceramic head. So now your new hip has a ceramic head and a plastic liner. 3 goals. Number 1, to get parts that fit well. Number 2 is to give you a stable hip that doesn't pop out of socket. And number 3 is to try to get your leg lengths the same length. Getting your legs the same length is the lowest priority, but it is something that we work at. But stability and the quality of the implant always trumps leg lengths, because the leg lengths come from too many other variables. Now, as far as recovery is concerned, we have a therapist come to your house twice a week for 2 weeks, have a nurse come to your house twice a week for 2 weeks. It's all simple, obvious comfort care. How do I walk? How do I get through my day? But I have no requirement on specific exercises or muscle strengthening exercises. A hip is going to essentially rehab as a function of time. As a broad generalization, when you see me at 6 weeks, most people are coming in walking without a cane or without a walker. Even though you're going to improve over the course of a year. You see the benefits of a hip replacement for about a year. 4 weeks, 6 weeks, you're not going to be able to bend over and tie your shoe because the hip kind of restrains you from doing that. But the hip is going to naturally tell you what it can and can't do over time.